first meeting this session of 2024 of the Senate Judiciary Committee. So welcome to everyone in the committee meeting room and following along online. We are in the second year of a biennium, but want to take just a minute to have our staff, who's always so hardworking and is really the backbone of the committee, if you will. If you'll take a minute just to introduce yourself and to let us know how long you have been working in the legislature. And we'll go ahead and start with our revisor first.
Thank you, Madam Chair. Good morning, committee. Jason Thompson, Senior Assistant Revisor. Just hit 17 years, so this is session number 18, mostly on Judiciary committees.
Good morning, Madam Chair. I'm Jenna Moyer, Assistant Revisor, and this will be my 8th or 9th, I think it's my 9th session, and I've been with the office just as long. And I believe I started staffing this committee in 2017.
Good morning, everybody. Natalie Nilsson, Principal Research Analyst with the Kansas Legislative Research Department. This is my 10th session, and I have been staffing Senate Judiciary, I think, every year since.
Elizabeth Cohn with Kansas Legislative Research. I'm a Senior Research Analyst, and this is my 2nd session.
And our IT person today?
My name is Lance Capshaw. This is my first session here. I'll be the AV tech person assigned to this room. Thank you.
Great. Well, welcome. And you are critical to getting our information out there to the public as we conduct our business. And last but not least, on our staff, we have, here, I'll share you my microphone.
Hello. Now? Okay. I'm Barbara Moore. This is my 2nd year as committee assistant to this committee.
Thank you to the staff. And I will say welcome back. And I will say welcome to our AV person who will be in the committee meeting room with us. And then we'll go around the room and we'll have committee members just please tell us who you are and the district you represent.
Thank you. Mark Stevens, Senate District 34, which is Reno County in the northern half of Kingman County. Thank you.
I'll go next, then we'll let Senator Baumgartner. So Elaine Bowers, Senate District 36, which is North Central, Northwest, Northeast, Central Kansas, 13 counties. Thank you.
Wow. Thank you. Senator Baumgartner, if you wanted to introduce yourself and your district.
Thank you. Senator Molly Baumgartner. I represent the 37th Senate District, which is Southern Johnson County and Northern Miami County state line, and about 20 miles west. Thank you.
Senator Rick Wilburn, Senate District number 35, centered around McPherson County and 6 contiguous counties around it. Thank you.
Ethan Corson, Senate District 7, which is Northeast Johnson County.
Senator Beverly Gossage, District 9, and currently it's all contained in Western Johnson County. But at election, we all move into our new boundaries, and so it'll be part of 4 counties.
Senator Rob Olson, all my districts, the 23rd district's in Olathe, the great city of Olathe, and here to serve the great state of Kansas. My 20th session. Thank you.
David Haley, Wyandotte County, wholly contained in Wyandotte County, the 4th District, Senate District, and pleased to be starting my 24th session on the Senate Judiciary Committee.
Well, thank you everyone for your service. I'm Kelly Warren. I'm representing Senate District 11, which is in Johnson County, the cities of Overland Park and Leawood, the southern part of those cities primarily. So thank you all for being here. And we did have a meeting scheduled yesterday. However, due to the weather, the Senate went kind of canceled all their formal business, and so the meeting of the judiciary was canceled. We do have a few tweaks to the committee rules, and we will pass out copies of the committee rules for members to become familiar with, and as well for our conferees and members of the public who wish to provide testimony to the committee. Please do, I would ask, make sure that your testimony is submitted 24 hours in advance of the committee meeting. With that, then, I will ask for any bill introductions from the committee. Seeing none, do we have any requests for bill introductions from those in the committee meeting room? All right, I don't see any for today. We will then move on to our presentation for today regarding assisted outpatient program and a presentation from the Kansas Department for Aging and Disability Services. So want to welcome Drew Adkins, the commissioner, to the podium, and please introduce yourself and welcome to committee.
Thank you, Madam Chair. Members of the committee, Drew Adkins, newly Commissioner to Behavioral Health Services at the Kansas Department for Aging and Disability Services. I don't think I've been able to meet all of you. I hope to at some point in time, but thank you for the opportunity to present. I also have with me our AOT program director and project coordinator. So between the two of us, if I don't know an answer, I may call her up. That's Jessica Mays. So we can go ahead and move to the next slide, please. All right, so today we're here to talk about assisted outpatient treatment, both in general and specifically what we're doing with assisted outpatient treatment in the state of Kansas. AOT, as I'll reference it from here on out, is the practice of delivering outpatient treatment under court order to adults with severe mental illness, serious mental illness, or a co-occurring disorder who meet specific criteria such as a prior history of repeated hospitalizations or arrests. It is specifically a tool for assisting those individuals most at risk for the negative consequences of not receiving treatment. Thank you. To further elaborate on that, AOT is the practice of providing community-based mental health and behavioral health treatment under a civil court commitment. This is to, one, motivate an adult with mental illness, either severe persistent mental illness or a serious mental illness, who struggles with voluntary treatment adherence to engage fully with their treatment plan, with their provider, an individual clinician that they're working with. And also focusing the attention of treatment providers on the need to work diligently to keep the individual engaged in effective treatment. So one of the questions that we usually get when we talk about AOT statewide is, who is this specifically for? One we've covered is an individual with severe persistent mental illness, serious mental illness, or co-occurring diagnosis. So usually that would look like schizophrenia, bipolar disorder, or a schizoaffective disorder. We also have here on the checklist someone who has a difficulty adhering to treatment. This would be an individual generally inside and out, have been in and out of treatment or state hospitalization. And I'm probably not going to pronounce this right. Anosognosia, there we go, thank you. Which is a lack of understanding that their illness requires ongoing treatment. And there at the bottom, just to make sure, and I've referenced this a couple of times, this does not exclude someone with a substance use disorder. So when I reference the co-occurring disorder, that would include those with a substance use disorder. Continuing that, who is the assisted outpatient treatment program for? We have here, it is roughly 0.2% of the population currently. So to build onto that, we have a dual diagnosis. I mentioned this is substance use, having positive trauma and or having suicide screens. We have homeless or unhoused or precariously housed, a transient individual. Again, repeat hospitalizations. And for the terms of this presentation, when we mention hospitalizations for AOT in Kansas, we're specifically referencing state hospitalizations. We're not talking right now about emergency department or emergency room hospitalizations. And then also repeat law enforcement contact. So someone that has been justice involved is usually how we categorize that and may have been going through the system. Next slide, please. Who are the key leaders for the AOT program? The stakeholders are some, if not some of the most important parts of the program, and essentially is the heart of any AOT program. There are a couple of rungs of this, which is community involvement and buy-in to the program outside of the walls of the judicial system and the community behavioral health provider as well. So we have our public mental health authority, either state, regional, or county. So that would look like in Kansas, the Kansas Department for Aging and Disability Services and Behavioral Health Commission. Regionally, that would look like your behavioral health provider and what their reach is for their service area or their catchment. And that would look like our certified community behavioral health clinics and our community mental health centers and other partners. And then the county, that would look like our judicial districts, our district courts and their involvement there. We also have our civil court judges and other court personnel, the mental health professionals representing community-based inpatient and psychiatric crisis services, the attorneys and the petitioners for both the DA and also the attorneys representing the public defenders or the respondents. The sheriff and or the local police are very important in this as well. And we also have here the peer mentors and consumer and family advocates for those that have lived experience to share their experience. So we put on here why assisted outpatient treatment. And I think this slide shows a lot of interesting facts just for the programs that we have had grant dollars to and been a pass through our federal grant dollars through the Substance Abuse and Mental Health Services Administration opportunity. It does, in essence, stop the revolving door. I won't go through everything on that table to the right, but I did want to include it. But some of the highlights there, we have hospitalizations down 77% in these specific areas. We have length of hospital stays down 43%. We have arrests down 83%, and the list goes on. As we start to get into the colder months and the colder weather, a lot of what we see and what we approve funds for at KDADS and behavioral health is to be able to put people temporarily up into hotels. And so looking at the homeless nights or the unhoused nights down 49%, I think is great. We also have a 40% cost savings to the system as a whole. Illegal substance use is down. And from our satisfactory, service and survey of that, 92% are satisfied with the AOT services. So we wanted to share that. All right. In the Kansas AOT program overview, and this could get a little confusing as we go through this. Right now, KDADS, behavioral health funds specific counties, and that would be the first 5 there that you see. And those are through, again, federal grant dollars that we get through the AOT grant. So that is Douglas County, Ford County, Cowley County, Ellis County, and Riley County. You'll also notice that Sumner County is on that list. We do have other federal COVID dollars that we received that they have been the recipient of to fund their AOT program. So still federal dollars, just a different pot, and they're doing that there in Sumner County. And I'll get to this a little bit later, but we do have other counties that are funding this themselves, and we'll show a map of that as well. Just a couple of things on the left before we move forward. Our first participant was in March of 2022, and our first graduate of the program was March of 2023. Next slide, thank you. So wanted to show this map for the population density and also the AOT programs. I mentioned this a couple of moments ago. So And I think I've got the colors. You'll have to excuse me. I have a little bit of color deficiency, but our red pins there on the map are the KDADS grantees. So those first 5 that I showed there on the slide prior. We also have our areas and counties that are looking at beginning the assisted outpatient treatment program. And so you'll see those in the light blue grayish pins on the statewide map. And then we also have established AOT programs that are in the dark green. The 3 that are established, as you'll see, and I mentioned, are in Wyandotte County, Johnson County, and Sedgwick County. And again, those are county funds that they are using. And this just elaborates a little bit more statewide on the demographics, but for all of the counties that are doing AOT, whether or not, regardless of their funding source, whether that's federal funds or county funds that they're using. And so we wanted to highlight that. And one of the big takeaways for highlighting this is to show the difference in the counties that are actually utilizing assisted outpatient treatment, from rural to frontier to metro, suburban, what have you. And we thought that this was really neat to show, and kind of bolded some of the demographics and some of those measures that we use for that. Just to elaborate, and this is specifically for KDADS grantees, so not all programs. We have 98 assisted outpatient treatment participants to date, and that's of January 5th of this year. Again, we had our first participant in March of 2022. We've had 33 discharges from the program. So right now our graduates are at 18, and that's a 54% rate. And we do have some of the demographics just for the grantees here as well, for you all to view at your convenience. This goes in a couple of next slides that we have goes into a little bit more of the outcomes for the rates of our KDADS grantees. Just as a quick reminder, on the left, you'll see the hospitalizations. Those are the state hospitalizations. So if you'll look at the first bar graph on the left there for pre-assisted outpatient treatment program enrollees, that would be 167 individuals. We have during AOT 34 individuals. That is a 79% decrease. And then our known arrest on the right-hand side, we have 87 individuals with known arrest, 16 for comparison there during the AOT program. All right, a couple more slides. Just our Kansas overview. I believe this is in general. This is not just the grantees. Is that correct, Jessica?
This is just the grantees. It's not even all of the grantees. This is only for 56 participants and 57% of the program. Can you hear me?
You might come up here if you can.
Please introduce yourself first. Thank you.
My name is Jessica Mays. I am the AOT program coordinator. Thank you for having me here today. This is actually only for 56 participants. I had one of my larger counties did not get me the data on days of hospitalization. So if you'll look at this, what you're seeing is a snapshot of half of my program. Just to give you an illustration of how many hospitalization days that you could, or that were acquired only by 57%. So when you look at 1,760 days, it's a lot of days. And if we were to average that out, you'd be looking at over 3,000 days. And then the slide prior, those are times of hospitalization, not individuals, because each individual is usually hospitalized multiple times before they reach the AOT program.
I think we can go to the next slide, please. So this will take you through how the AOT program works, and it'll also, in a couple of subsequent slides, talk about how it is different than the OTO and we will, the outpatient treatment order that we have today. It starts with the emergency custody, goes to our evaluation and treatment. We then have the petition for commitment, have the judicial review and the decision from there, the inpatient commitment until they are stabilized. We have the discharge planning and the petition for the AOT program. We have the judicial review decision, and then that is when the community treatment of AOT gets involved. And from that, if successful, would be a transition to voluntary treatment into the community. So these first 5 steps, going from the emergency custody until the individual is the inpatient committed is stabilized. They're currently required before a person can be entered into the AOT program. The timeline for these steps do vary dependent upon the level of help needed, how long it takes the judicial decision, and then the treatment effectiveness. So the AOT, and I mentioned this earlier, is an outpatient treatment order. The biggest difference here is that a judge in a community mental health center or a certified community behavioral health clinic must agree that the individual is in need of further treatment and the oversight meets the criteria for the AOT outpatient treatment order. So a refresher on the outpatient treatment order for step 6 and the criteria for that for the inpatient or outpatient commitment in Kansas is we have a mentally ill person. This individual lacks capacity to make an informed decision concerning their treatment and is likely to cause harm to their self or others. And the piece of this in KSA 592946 is that the diagnosis is not solely a substance use disorder, so alcohol or substance use, personality disorder, intellectual disability, organic personality syndrome, or an organic mental disorder. So to elaborate on the order for the outpatient treatment in Kansas, this may be entered by the court at any time in lieu of any type of order which would have required inpatient care in the treatment if the court finds that the patient is 1, likely to comply with the OTO, and that the patient will not likely be a danger to the community or be likely to cause harm to self or others while subject in that OTO. So the criteria for the AOT, once an individual is stable enough for an outpatient treatment order, if they meet the following criteria, that would be, again, an individual with severe or persistent mental illness or serious mental illness, co-occurring disorder, usually schizophrenia, bipolar disorder, schizoaffective disorder, pardon me. We have an individual that is difficult or having a difficulty adhering to treatment. They have been in and out of treatment and or state hospitalization. And also I'm going to butcher this again, I apologize, the anosognosia, I believe. So the lack of understanding that their illness requires them to be enrolled in ongoing treatment. So here we have a pivotal change and I would say enhancement from the current OTO into the assistant outpatient treatment. We have the judicial review and decision. We have a judicial involvement and the oversight that is more enhanced for the individual. We have, and I'll get to this in the next slide, I believe, too. We have the involvement of the community mental health center and them providing the directive and treatment planning for that. But that increased partnership between the either CCBHC or CMHC and the judicial branch, usually the judge, for that AOT is a big change from the OTO. And we mentioned this earlier. I know I've heard this a couple of times, and I'm sure that Jessica would agree, and those that have been in the AOT program with our community providers, but there is a black robe effect of having a judge being involved with that process and some of the success that we've seen from that. Again, they are a very key participant in the AOT success, and having the judges and the court staff, not just the judges, but their court staff and personnel play a role in that is very crucial. I believe this was mentioned earlier, but the AOT judges are civil court judges. The AOT noncompliance is penalized only with a new ex parte emergency custody hold. The AOT hearings are conversations. They're not as traditional as hearings, as say a criminal hearing or another civil hearing. The judge really is concerned and invested in the patient's success and viewpoint and what may be their best interest. Also very involved, again, with the community provider. A lot of the times that would be our CCBHCs and CMHCs and what their perspective is to get this individual to be back in the community of their choice and receive community-based services. So for the judicial review and for the AOT judicial process, after the initial competency hearing, the judge will set the first AOT hearing. The judge will meet with their participant at least every 30 days until progress is shown. This is a difference. This is another key difference in the OTO and the AOT from what we've seen is that meeting is a tad more frequent than the OTO meeting would be on a regular outpatient treatment order. The length between hearings will increase with participants' progress and their involvement and enrollment with the community-based services as in the AOT treatment planning. And at last, the participant will graduate from AOT when the judge and the treatment team feel the participant will voluntarily continue with treatment. I won't spend a lot of time on this, but I do want to stress the involvement also of the community treatment providers. Again, those are our CCBHCs and CMHCs, of which now we have multiple that have either received dollars directly from KDADS or have done this on their own because they've seen the success. And so having them agree to have dedicated resources, court liaisons, AOT staff, those individuals that will ensure the success of these providers is very crucial and is a lot of the crux of the AOT process. So just as with treatment planning, every AOT treatment plan must be tailored to the specific individual needs of the participant, which may vary greatly in intensity. A lot of the times you're dealing with a population that may not have a driver's license. They may not have any of their documentation. They may have bounced around in the state. They may have come from a different state. And a lot of the times finding individuals such as the AOT case managers that can really focus and carry a small caseload, not be overwhelmed by a general caseload or a large caseload as some of our other case managers are, allows them the frequent contact with each of their participants and allows them to make sure that they're abiding by what is laid out in their treatment plan. But also, are there other things outside of mental and behavioral health services they can help get the individual connected to ensure success in the community? The treatment team members also must monitor the participants' adherence to their treatment and observe for any behavior changes similar to previous behavior that preceded a psychiatric crisis. And for the CCB, the Certified Community Behavioral Health Clinic and Community Mental Health Center, this would be them taking on another client. But again, hopefully at that point in time, that case manager, that liaison that's a part of the AOT program would be able to dedicate a large amount of their time and resource to making sure these individuals are successful. Some of the wraparound services for the individuals. I won't go through all of these, but some of those to highlight for the core services are the screening and assessment, any pharmacological, psychopharmacological services, again, trauma-specific services, the individuals that are seen in these programs obviously do carry a lot of trauma. A lot of the time they are bouncing around from different systems, whether that be potentially a state hospitalization or a justice-involved individual. And so those core services being specifically tailored to them are very paramount. And then co-occurring services for those that would be appropriate for. So if you have somebody that does have a co-occurring diagnosis, making sure that there is supplemental services for that co-occurring disorder. Support services, again, would be any type of primary and behavioral or primary physical care, employment services, family services, child care, peer support services, housing support. A lot of the time, other programs that we have at KDADS and in behavioral health will focus on how do we get this individual access to permanent supportive housing? How do we get them out of a situation where they may be bouncing around in a hotel or another temporary stay, to get them set up for success in an apartment, get them, last month's rent paid? How do we get them into an ebb and flow to be successful? And that starts with housing, then maybe bringing in employment services after we've established a baseline. So step 9 is the last step in the assisted outpatient treatment program process, and that would be a transition to voluntary treatment. So this would be the individual agreeing and deciding to embark on voluntary treatment as they've seen success with the treatment they've received in the AOT. This would be making sure that they're connected where they are going to be, where they live, work, and play. That they would have services available to them through their community mental health center, CCBHC, or other providers that they need. All right. I think I might have a different slide, so I'm going to read off the screen here. I apologize. So the release from the assisted outpatient treatment program and the graduation there isn't about the time of the program, but the progress made. It is dependent upon the participant, their involvement, also dependent, again, as we've mentioned, on the CCBHC team and the CMHC teams. And again, a big factor of this is the judge and how much they can invest in the individual. The criteria for release is treatment plan adherence, making sure that they're still connected to their treatment plan, the progress and the quality of life, and the commitment to continuing care. And I think we can go to the next slide, please. We are working, one of the main goals whenever we receive a grant, and it is temporary grant funding, is to discuss and figure out how do we make this permanent, how do we make this sustainable, especially when we find success in programs. A lot of the time we talk about funding in that way. One of the other pieces of this is what do we need to see changed within the current environment, within the current statute, again, really referencing more of that outpatient treatment order. And so some of the proposed legislative changes that we have that we're interested in this legislative session would be, 1, extending the ex parte emergency custody order from 2 days to 3 days. This would be because we've seen tremendous success in doing that with our grantees and with the other programs that we have. Also adding decompensation standards to the outpatient treatment order criteria, having the centers provide the directives and treatment plans to the court. If I mentioned this early on with the AOT, that is one of the bigger differences. And so having that reflected within the current state statute, and then expanding the initial outpatient treatment order from 3 to 6 months. So those are a couple of things that may pop up this legislative session that we're looking into because we've seen success with that for our OTO and the AOT program. And I think that is it. We put some contact information for Jessica. She's our program director. Feel free to reach out to either of us, but I'm happy to take any questions. And if I can't answer your question, I'll bring Jessica back up here.
Thank you for that thorough presentation. It was very enlightening about this program, and I did a little bit of research about where this program came from, where it is housed in our statutes, and if the revisor can correct me if I'm wrong, but back up for a minute. One of the reasons I brought this to committee today is often we hear so much about what our courts do. We don't often hear, though, about how our courts are impacting and helping with treating mental health, mental illness. We do have the drug treatment courts, and this is, though, on the civil side. In this committee, we also are asked to look at the probate code very often to amend our trusts. How our trusts operate and are structured. And this program falls in the probate code. So it's another part of the probate code. It's chapter 59. And so wanted the public to be aware of what also happens in our probate code and why this is a civil matter then and not a criminal matter. However, also important for this committee is that it does impact, you had said, reincarceration, arrests, and hopefully keeping the folks who are needing this program out of the criminal justice system and getting them the help they need. I think this act was created in 1996, so almost, over 25 years ago. And the act about the judicial review, the orders, was last amended in 2010. So from what I can tell, and again, the revisor can correct me if I have any of that information wrong. So it's something that impacts our courts, and I'm glad to hear about the judicial review and how that works there. So I have one question to start us off with. You had said that the first participant in this program, you had said that the first participant in the program was March of 2022 and the first graduate in May of 2023. So the program from the perspective of KDADs is relatively new, or what happened in March 2022 that started the reason for your presentation today?
That's a great question. I'll probably bring Jessica to provide her perspective on that, if that's all right, Madam Chair.
Good morning again. March of 2022, the grant started in 2021. It took our groups about a year to get set up. It takes about a year to get all of the stakeholders on board, to get the community involved, to find the correct judge, because it can't be just any judge, it needs to be the right judge. And then, so we started March 22. Our first graduate, it takes almost a year to get through the program properly. We do have those that graduate earlier, but the program really does take at least a year, and they've shown greater results if they make it a year plus. So if they go 14, 15 months, we see that they don't usually come back into the program again.
Thank you. And several of our committee members represent part of Johnson County. And when did the Johnson County courts start their program?
About 2.5 years ago.
Okay, so around the same time, a little bit earlier.
And Johnson County has done an amazing program, and their judge has been instrumental in helping us develop our programs as well.
And which district court judge is that?
Be Judge 1L.
Okay, thank you. Committee questions for our presenter. Yes, Senator Gossage.
Thank you both. And Jessica, I'm glad that you're staying up here. So some really quick questions on, and I don't see slide numbers, but there was a part of the chart that said no health insurance in less than age 65. And I'm wondering, does that include the short-term medical plans, Christian sharing, and the Farm Bureau program?
As far as I know, most of our participants actually come in with maybe private insurance if they do, but I'd say about 75% of them, we have to find them Medicaid insurance or otherwise. And we get them.
Could you make sure you speak into the microphone so those
Sorry.
following online can hear?
Apologies. So we try to get them set up with services and in some form of insurance as soon as possible. And they get very creative at the centers on how they do this because they, of course, don't want, for the non-insured, part of our grant will cover some of those fees, but we try to make sure that they do have coverage of some sort.
Jessica, would you mind finding out if those were actually included? Thank you. And Madam Chair, if I may, a couple of other quick questions. And it says graduates 18. So is that 18 of the original 96?
That's 18 of the original 96. Now, like a revolving door, our participants are coming and going. So they cycle in and out. But yes, we are at 18 graduates. And the extra discharges, the ones that did not graduate, we don't necessarily count those as failures. Most of our discharges that did not graduate are situations where we've transferred them out, a good portion of them. And transfer out means they got 3 months into the program, reconnected with family that they haven't spoken to in years, and decided they wanted to move to South Carolina or Texas. They wanted to reunite with their family. So we connect them with services in the state or county that they're headed to, and then we discharge from there. We've also had a few that are medical situations where, as we get into the program, it becomes obvious that this person is not able to physically or mentally care for themselves, and so they end up in a long-term facility. But 9 times out of 10, if it's just discharge, they've connected with family and gotten back home.
So then my question, and thank you for that. So my question of the graduates, it says 18 and then it says equals 54%. That's my confusion.
54% of our discharges.
Of the discharges.
Of the discharges.
Okay, that makes sense. And then finally, Madam Chair, the number of staff that are involved in this.
There are about, what did I count? Last time was 29 people on the AOT. I'm the only one, of course, for the state. But in each of our centers, they range from 2 to 4 staff. And that's just what's on my grant. That doesn't count your therapists, your case managers, who are committing minimal level of effort, but are still helping.
And that would be the CMHCs.
Right, the CCMs, CCPHCs in this, yes.
That would be
I didn't hear that. I'm sorry,
That
Drew.
would be the providers.
Could you make sure you're speaking into the microphone? Thank you.
That would be the providers. So I don't know if there's a total, if you were asking more, however many staff are involved total, but that would just be the community mental health centers and the certified community behavioral health
Okay,
clinics.
so not like staff as part of the grant. You're the only staff member as part of the grant?
Yes and no, it's schematics. I am the only one that is required at 100% level of effort, but in each of my centers, there is an AOT coordinator and an AOT case manager. So they are designated to that position.
Okay. Thank you so much. Thank you, Madam Chair.
Thank you. Committee, other questions? Senator Baumgardner.
Thank you, Madam Chair, and thank you both of you for being here to testify. I'll pull this closer. So I am looking at the slide on the deck that says why AOT. That's got some information about stopping the revolving door. And it indicates that hospitalizations are down 77%. The length of the hospital stays are down 43%. Victimization rates are down 52%. Things like that. So share with us how you came up with that data.
These are national statistics. So the Treatment Advocacy Center put these through. The state statistics are on the state slides. And we're new enough that we're not able to get some of those stats yet without pinpointing, because you need a certain database. And we only have 98 participants, which is great because, again, we're dealing with a very tiny population. But some of these are national stats. Hospitalizations down 77. Those are Johnson County statistics. Those are what they're seeing in Johnson County. Length of hospitalization stays, that's actually from South Carolina. Some of these are from Iowa, but they are all from a report that I'm happy to send forward from the Treatment Advocacy Center.
Okay, I think it would be helpful if you could provide us with that addendum as to which are specific to the state. And And I guess, Madam Chair, when I look at the next page, which is the grant has 5 pilot sites. And when I'm looking at that, with regard to the pilot sites, so what's happening with the hospitals at the pilot sites? Is that a reduction in hospital stays?
Yes, that is on,
I see.
that is this one, the Kansas overview.
Mhm.
These slides, number 12.
Page
12.
Okay. And our copy of the deck doesn't have the page numbers on it, but I know which one you're looking at.
Okay.
Because I'm looking at that also.
Now
But
this is solely Kansas.
Okay. And I
my
guess,
sites.
Madam Chair, I only bring that up. We're talking about hospitals. And what we've been hearing with several political entities traveling through the state is that we have a problem with hospitals, and we don't have enough population in the hospitals, and hospitals may have to shut down. So,
To define hospitals, these are the state hospitals. This
Okay.
is Osawatomie and Larned,
okay.
and they never have a problem with not having a full bed.
No, we don't, but we've had a problem with being able to get people in there. So when we're talking about those hospitals, could you please, when I look at the reduction, 77% and 100%, could you break that out based on the 2 state hospitals for us? Thank you.
I can put down that it's for the 2 state hospitals, but I'm not sure for HIPAA purposes if I can go much deeper, because a good portion of our folks come from one hospital and not necessarily from the other. So to narrow it down, if I've got 10 participants that have only been, say out of Osawatomie,
Right.
it narrows down very closely, and my evaluator, who does most of my data, would be very angry with me, but I am happy to drill it down as close as I can without getting close to violating HIPAA.
Well, Madam Chair, I just think we need clarification, because when I'm looking at those slides, as far as days in hospital reduction, you're saying now it's Larned and Osawatomie, but when you talked about this page of the 77% down, you said that's specifically Johnson County hospitals. And Osawatomie is not located in Johnson County. So a clarification of which hospitals those would be helpful. Thank you, Madam Chair.
Yeah.
Thank you. I have a follow-up question to that. The slide that represents that hospitalizations are down and that's a good statistic. Could you explain why that's a good statistic that AOT participant hospitalizations are down?
The reason it's a good statistic is because it means that our people are stable. They're on medications, they're going to treatment, they are receiving the treatment that they need. When you look at the revolving door, these are people that they're known in their communities. People know these people. They've been in and out of treatment and services over and over and over again. And once we get down, we had one woman that had 26 hospitalizations in a year. And she entered the AOT program. There was one that she went back in, 1 or 2, and she hasn't been back since she graduated. What we're seeing is that they're getting the treatments they need in the area they live in, and they don't need to be rehospitalized, because with the addition of the judge and their treatment team, they're stable and they're happy.
Thank you. Committee, other questions? Senator Baumgardner.
Thank you, Madam Chair. And I guess that just takes me right back to, so I appreciate the anecdotal story, but when I look at this presentation, we're talking about hospitals as if they're all the same. And there is a difference between a hospital that's in our community. So I'll use Miami County because that's where Osawatomie State Hospital is. So we have the Osawatomie State Hospital. And then we have the Miami County Medical Center, which is now a part of the Olathe Medical Center, which is now a part of KU Medical Center. So I think it's really important that, to me, for this to be meaningful,
Absolutely.
we need to know. So the 55 visits to a hospital in a year, are we talking it was a state hospital, or are we talking it was a community hospital?
Madam Chair, Senator Baumgartner, I believe those are great points. What we can do is take that back and further dive into it, peel it apart, and make sure that we have the specifics there. I agree. We need to make sure that we have all of our ducks in a row and are all speaking from the same statistics. And so we'll be happy to do that, provide an addendum to the committee. Absolutely.
Is one of the benefits that you talk about of the program on one of the slides, the Kansas overview slide regarding days in hospital cost for only 56 participants or 57% of the total program? Part of your chart says that hospital stays average $734 per day, and roughly 61% of participants have Medicaid and 20% are uninsured. Is this what is the, and I'm sorry, I know you talked about this slide earlier, is the impact of what you're saying here, is saving dollars for Kansas from the Kansas budget, or could you just clarify that?
What I'm attempting to illustrate is that it is saving for the communities. And be honest, I should have probably scrapped this slide because the data is incomplete. But the point was to say that, yes, we are saving money, because if you can get outpatient treatment as opposed to waiting until things escalate and they need law enforcement and then state hospitalization and extra care, then we can save money.
And law enforcement comes with cost as well for our law enforcement community. And I'm sorry if I didn't understand, either grant money comes from SAM-HSA, that acronym on the slide of the program overview.
So that's a agency administration within the Department of Health and Human Services at the federal level. So there are federal funders for a lot of the projects that we do. This is Substance Abuse and Mental Health Services Administration. And so the funding that we received for the 5 pilot sites that are noted there, that came through, and KDAD's passed that through to those sites specifically.
Okay, so it's federal grants, and it's $4 million from March 2021 to March 2025?
That is correct.
Okay. Thank you. Any other questions, committee, for our conferees? All right, Senator Steffen.
Thank you. And looking at this, the patients, is there any point that they can fail or exit from this program, or are they, it looks like from what I've seen, there's no accountability, no responsibility, and no exit strategy other than your all's permission. Help me understand that.
Well, this is why there's so many slides, partly, but because the way AOT is set up, as it is a civil court order, if someone doesn't show up, there's not much we can do. The CCBHCs and the CMHCs will reach out. They will follow up. They will try to make additional contact. The judge, most of our judges prefer not to do an ex parte custody order to have somebody picked up. But there really isn't much, there aren't a lot of teeth, which is the black robe effect. But the exit strategy, all of our people have attorneys, and these attorneys are set to represent their clients. They can petition the court at any time to release someone from an outpatient treatment order. It's the same as it's always been. They just need to petition the court. And usually when we reach that point, the judge knows it's coming. But there is an exit strategy. And then if that person says the keywords we're looking for graduation are that I think I need to continue my graduation or my treatment on my own, and then the court will release.
Thank you. Committee, seeing no further questions, want to thank our conferees for your testimony today and appearing in committee. And also want to alert you to a change for next week. You'll see it on the agenda, but want to start alerting you. Next week on Tuesday, we're not meeting on Monday, it's a holiday. Tuesday, we will be meeting jointly with the House Judiciary Committee in this same room, but we are changing the time. We're changing it to 3:30. So I'm anticipating that our work on the floor that day, Tuesday, January 16th, will be done in time to start at 3:30. And the purpose of us getting together is to have an update from the judiciary. So we're anticipating, we've talked with Chief Justice Lukert. She's going to be providing the state of the judiciary address to the state today at 1:30 p.m. So please have any questions ready. We're going to be getting an update regarding the cybersecurity attack and a little bit of budget and how our courts are processing any speedy trial issues and just kind of a robust, hopefully, update from our judiciary. So in this room, but different time, 3:30, January 16th on Tuesday. And with that, seeing no other business before our committee today, thank you for your attention. And stay tuned for an announcement on the floor today that we may not be meeting tomorrow. We are not meeting Friday. We're already scheduled not to meet Friday, but stay tuned today on the floor for whether we'll be meeting tomorrow. And with that, committee, thank you. We are adjourned.